David Denning, no stranger to most of you, qualified in medicine at Guy's Hospital in 1980, worked at Northwick Park Hospital, Stanford University with David, and a little time in Glasgow. Eventually ended up in Manchester in 1990, became a consultant in infectious disease, given a chair in 2005, and I suppose most recently, from the point of view of those in the UK, was able to persuade the Department of Health to fund a national Aspergillosis centre, which is what he's going to talk about now, chronic pulmonary aspergillosis. Thank you, David.
Thank you. Well, it's a pleasure to be here. Thank you for coming. I hope what I'm going to say is useful for you. The topic is broad, the whole area of aspergillosis, and I'm going to deal with one particular piece, which is this area of chronic pulmonary aspergillosis. You've seen this slide already. What is superimposed on this is the relative numbers in the European Union before the most recent expansion of the different countries. And you can see the relative numbers of patients there. So there's many, many more patients with allergic fungal disease than there are patients with either invasive disease or chronic disease. But there's also a difference in the way that they're counted. So once you have allergic fungal disease, it goes on and on and on. When you have invasive disease, you have an episode and you either survive it and get better, or you don't survive it. And so it doesn't tend to be chronic, with only a very small, a few number of exceptions. So chronic pulmonary aspergillosis comes in several forms. One of these forms is as what's called an aspergilloma, or a single fungal ball in a cavity in the lung. And this is a cavity that's already there, typically from tuberculosis, but often from other causes. And this is an example of what it looks like. This is a CT scan of the chest in a young woman with a disease. And you can see a cavity here with a fungal, what we presume is fungal ball material in there. And when this was taken out, it was confirmed that it was actually fungal material in there, all Aspergillus. And she came to the hospital because she coughed up blood. She had antibodies in the blood against Aspergillus, and she had a lobectomy taken away, and she was cured. The test, this antibody test, was described actually originally at the Brompton Hospital in London in the 1960s by Joan Longbottom and Jack Pepys working together. And it's a precipitating antibody, so it's known as precipitins. And you put a little bit of extract of Aspergillus in the middle of an area of agar, and then you put patient's blood, actually the serum rather than the whole blood, there, and then the Aspergillus extract diffuses through the agar and the antibodies diffuse, and you get these precipitating lines which indicate antibody. And this is therefore fairly old tech type testing, but actually it works quite well, and we use it as the basis for the diagnosis in almost all of the patients that we see. So a fungal ball looks like this if it's removed. This is a Brazilian fungal ball. This is a Manchester fungal ball. Not a lot to choose between them. They're rather irregular. The Aspergillus that's there is in a biofilm type formation, so it produces a lot of sort of surrounding material to protect it from external influences, including white cells and antifungal drugs. And it very slowly grows and changes over time. It's a really slow burn type of problem. Almost all of the cases are due to Aspergillus fumigatus, but there are descriptions of other fungi such as Aspergillus niger, Aspergillus flavus, and occasionally other non-Aspergillus fungi that can cause these fungal balls, but they're pretty rare. There's well over 98 to 99% are caused by fumigatus. So that's the single fungal ball, but the other thing that you can get is what we renamed chronic cavitary pulmonary aspergillosis, was before that called a complex pulmonary aspergilloma, so multi-cavity disease. And these patients don't have to have a fungal ball. They often do, but they often do not as well. And they present, these patients, if you have this disease, with cough, which is usually productive, but not always, with shortness of breath, weight loss, tiredness, coughing up of blood, and sometimes some chest ache or discomfort. And the degree of the different types of these symptoms varies a lot from one person to another. So some people, their biggest problem is tiredness and weight loss. Others, the biggest problem is coughing up of blood. And for other people, it's cough, which is incessant, keeps them awake at night and productive and so on. Now, sometimes you get fever. That may not be due to the Aspergillosis, it may be due to a bacterial infection, but sometimes they get fever. Sometimes patients cough so much they fracture a rib, and so they have really a lot of pain, which is localized to a specific area. Many of these patients have very frequent chest infections from other bacteria. And in the much older type of patients who disease is not controlled, we see a slightly higher incidence, I think, although we haven't measured it very accurately, of angina and heart attack type of problems, which seem to be related generally to inflammation. So patients who have a lot of inflammation are slightly more at risk. And so one of the aims of therapy is to reduce the amount of inflammation, to reduce these risks. I don't think these risks are very high, but that's sometimes how the patients come to medical attention. So Nicola Smith, who's working in our research group, has looked at around 120 patients who've come to our clinic. And the underlying diseases, and many patients have more than one underlying disease, are shown here. And this adds up to a lot more than 100%, as you can see. And on average, patients have 2.5 chest diseases underneath their chronic pulmonary aspergillosis. Some just have one, so they've had TB before, they've got sarcoidosis, but many have multiple underlying diseases. And there's a small number of patients with no apparent underlying disease at all. They just seem to get this disease. If you look in the literature, as Nicola did, you can see other reports of different underlying diseases here. I don't propose to go through all of those in any detail, but I do just want to highlight both classical, that is standard tuberculosis, and atypical tuberculosis, ABPA that Rick Moss has spoken about, not usually in cystic fibrosis, actually in asthmatics. And pneumothorax is also seems to be an issue. So that's people have a popped lung related to probably a little air pocket within the lung which bursts sometimes, and air gets around the lung. And that seems to be a risk factor for this disease. So when you look at the x-rays, and this is pieces of chest x-rays, in one case a scan, here you can see an area which is abnormal. This one has a fungal ball in it here. This is a similar cavity here, but with no fungal ball. And there's some additional cavities under here. Here you can see multiple cavities in different areas there. And this is a patient who has large empty cavities. She had tuberculosis, and essentially the whole of this lung is destroyed as a result of the combination of tuberculosis followed by aspergillosis. And she's left with these large air spaces with essentially no functional lung left on that side. So these are the typical types of pictures that we see on X-ray. And I want to show you this particular patient who came to see me some years ago, who was a young woman. She was a smoker, but that was the only underlying disease that we could discern in her. And she has X-ray abnormalities on both sides of the upper parts of the lungs, more severe on the right side here, your left, but abnormal on that side. And if you showed this X-ray to many chest physicians, they would suggest that the patient had tuberculosis. She was tested for tuberculosis. She didn't have tuberculosis. And a year later, there's a big change in her X-ray. She's got air spaces now up here, a lot of inflammation down here, and some what we call pleural thickening on this side. So the lining of the lung is very thick as well. And if I just go back, you can see how much that's changed in the space of a year. And then she went on a year later after that to get even larger air spaces, cavities here. There's a new cavity there, another one here. And there's the beginning of a little fungal ball on this side, on her left side. And a few months after that, this space has increased again, this cavity's increased with a fungal ball visible there, and now you can see this fungal ball here, which probably was present here, but you just couldn't see it very well. And so this shows you that over a period of about 2 years, or probably early, she probably had this disease for a year before she first came to the doctors, she's had very remarkable destruction of the upper parts of both lungs. And she doesn't have any underlying disease. She's not got, leukemia or transplant or anything. So this is the type of disease that we're dealing with. This is a particularly severe variety, but there are many patients with much milder disease who progress very much more slowly and aren't as ill as this woman was. So this is another woman here who had tuberculosis, little fungal ball there, and a lot of destruction on this side of the lung. So the bottom part of her right lung is normal, but the upper part is destroyed, and her left lung is fine over here. And this is the sort of material she was coughing up every day and continues to cough up some years later. Here's another patient who's got an abnormal X-ray on both sides due to sarcoidosis and a large single cavity up here with little, very small, little additional cavities. And this patient came to attention by coughing up a large amount of blood. This is the type of way these patients come to the doctor. Now, sometimes you can have a patient who develops invasive aspergillosis which doesn't quite resolve and becomes a chronic patient. And we've also seen a few patients with community-acquired pneumonia. So they're apparently normal, they come in with a chest infection, they have new shadows, and it evolves over time to cause chronic cavitary pulmonary aspergillosis over 2 to 6 months after that pneumonia. It doesn't completely resolve. We also see patients who evolve from chronic cavitary disease to chronic fibrosing disease, and I'll show you an example of that. So this lady had atypical mycobacterial infection originally. She's got a large cavity there and lots of small little cavities at the top of this lung here. She wasn't able to take itraconazole. She wasn't able to take amphotericin. This was before the days of voriconazole, posaconazole, caspofungin. And a couple of years later, that cavity's got a fungal ball within it. So it's progressed over that time in that sense, but the area involved is the same. And then a few months after that, she developed the lower part of the left lung became scarred. And this is what we call chronic fibrosing pulmonary aspergillosis. And I think untreated, this is the natural history of the disease in some patients. And why it affects the upper part of the lung here, and then suddenly the lower part of the lung is not clear, to me at least. So there are some subtle immune defects in these patients, many of them. Many of them we haven't figured it out yet. And Nicola Smith and I and others in our group are working to try and understand this a bit better. So some of these patients are defective in mannose-binding lectin, some in surfactant A2, toll-like receptor 4. Other people have just tried gamma interferon production defects. There seems to be a Phi2-dominated cytokine profile, which is a bit of a confusing term, but it means a more allergic type of pattern of response to inflammation. And we've recently noticed that many of our patients have really dismal responses to standard bacteria that cause pneumonia, like Pneumococcus pneumophilus. And we now test for these routinely and try and immunize as best we can. So what happens to patients with CPA if they're untreated? And actually, in this case, some of them were treated with surgery. There's no medical therapy, no antifungal therapy. And this was work that came out of the Brompton Hospital once these tests were introduced, starting as early as 56 up to 1980, and they published it in 1983. So pre-itraconazole, the only antifungal they could use was amphotericin, and sometimes this was put into cavities, but not many of them. So the best patients underwent surgery, that is the best in the pulmonary sense and the health sense, and they did a bit better, but it was a self-selected group of patients who were a bit better. And over 7 years, roughly half of the patients with untreated died of CPA. But even, and if you take this forward 15 years, in fact, there's still, many of the patients are still alive after that period of time, and this graph keeps going, it just they didn't count any longer. This is a very small study from the States with 13 patients with TB and 12 with sarcoidosis, and you can see that there were much worse outcomes in the sarcoidosis patients than there were in the TB patients. And I suspect that's because they received steroids, although we don't know that for sure. So the general treatment for this disease now is, for an aspergilloma, a simple aspergilloma, is surgery, and Dr. Massard is going to talk us through that. And for chronic cavitary pulmonary disease, itraconazole or voriconazole, which there's not very much data for both of these, but there is some. And then when they fail, if patients fail that or have toxicity related to that, then the other drugs that are used for invasive disease can be used. We also have patients who do cough up a lot of blood, and there's a specific strategy for managing those patients. This is an example of the image that you get under screening. So this is a catheter which is fed up through the aorta into the bronchial arteries. It's a little bit of dye is injected, and it flushes out very quickly through the vessels. And you can see this sort of blush of additional vessels here, which is abnormal vessels related to an aspergilloma. And then the venous drainage is down here. And these patients, most patients with CPA just have a little bit of hemoptysis and a little bit of coughing up of blood, not much. But some patients have very dramatic hemoptysis, which is a problem. And we initially treat them with tranexamic acid, which improves coagulation. And then we do bronchial embolization if we can. And this was a patient undergoing bronchial embolization who did well following that embolization. And in our center, we probably do this in about 10 patients a year. And sometimes there are multiple vessels involved, and sometimes it's just one vessel involved. But it can be hard for patients to lie flat for a long period of time to undergo this. I'm not going to talk about surgery because Dr. Massard is going to do that, but this is an important component for certain patients who've got reasonably good respiratory function. There's a very recently published paper from Korea where they looked at a particularly severe group of patients with CPA, and they followed them, as you can see, for many months over here. And what they noticed was that there was, early in the course of these patients' treatment, many of them unfortunately died. And this is because they came very late and were really sick, very thin, wasted, coughing up a lot of blood, infections with other organisms, and so on. But once the treatment started to bite and work, the patients then did really quite well. And most of them actually continued and were fine on treatment for long periods of time after that. So this early phase of trying to get patients better who are very ill is very important in terms of trying to produce long-term good outcomes for patients. So we treat patients for long periods of time, and one of the questions that often arises is, can I stop my treatment? And patients are forced to stop their treatment because they get toxicities from one of the medicines. And one of the patients, who's actually, his whole story is on the Aspergillosis website as a video, is here. I've been looking after him for nearly 19 years now. And we got him better with itraconazole. He did actually have a bit of voriconazole in the early clinical studies. He had a bit of amphotericin and so on. But we really got him quite a lot better with a very good outcome radiologically, with thin-walled cavity there, a little bit of pleural thickening. And he had no inflammatory were normal. He had only just detectable Aspergillosis antibody tests in the blood. And so after 5 years of treatment, we decided to stop therapy. And within 3 months, he was worse. His X-ray changed very significantly. He had a cough, he'd lost weight, his tests became abnormal, and we put him back on therapy. And we've re-established control of his disease. So our general view is that these patients need very long-term therapy to prevent this happening. But sometimes that's not possible, and so we need to think of other strategies, and certainly new drugs, when they come through, will be helpful for the treatment of these patients. Another problem that arises is antifungal resistance, and this is an example of a patient who actually from Africa with CPA following tuberculosis. She also happens to have HIV infection as well, but that's under control. She coughed up blood. She had an Aspergillosis test titer of 16, which is moderately high. And she had these two very large fungal balls in the lung here. And we had a discussion with her and our surgeons, because normally if you just had one of these, she'd be a very good candidate for surgery. But because the whole lung was effectively involved, she would need a whole lung out. And there's actually quite a lot of functional lung around this. So we decided to treat her with itraconazole. She took that. She had slightly low levels of itraconazole, unfortunately, for various reasons. And in February, she was doing pretty well. Her CD4 count was high, which is good enough. She had a low viral load, so her anti-HIV therapy was under control. But she coughed up some new blood, and her antibody test went up by one titer. And you can see in her scan here that there's no change to this area at the top here, but the middle area here has increased in size quite dramatically in 2 months. And we then grew Aspergillus from her phlegm, her sputum, and you can see that it's completely resistant to itraconazole, which she was taking. It's on the edge of being resistant to posaconazole, but sensitive to voriconazole. And so we switched her to voriconazole, and she's now doing fine on voriconazole 2 years later. But this problem with resistance occurs not infrequently in our patients, and it's a problem when we've only got one group of antifungals to treat the patients with by mouth, that is itraconazole. And this is the experience that we've got with very little resistance up until 2004, but increasing problems with resistance since 2004. And many of these isolates, Aspergillus, are resistant to all of the azoles, which is a problem for us. So the principles of treatment in these patients are that because they have important defects in innate immunity, we give them long-term antifungal therapy. Itraconazole, voriconazole, and posaconazole are all effective, but they do carry some side effects in some patients. Many patients get away with no side effects, but there are some who do have side effects. We have found that short or long courses of amphotericin B intravenously are helpful, and particularly in patients who fail the azoles or have resistance. We do use gamma interferon sometimes, and that seems to be helpful for a small group of patients. We haven't yet worked out how to test the patients properly to know whether they're producing gamma interferon to Aspergillus, and that's one of the things that we're working on at the moment. And it's very important to monitor for azole resistance in these patients, continuing repetitive basis to pick that up. And with that, I will stop and thank very much all the colleagues that I work with in Manchester, who are a pleasure to work with. Many thanks.
Thank you very much, David. So David's paper is open for discussion if there are any questions. It is really quite these three talks have been very interesting in showing the contrast between three extraordinary diseases, and martyrs will also help to add to that spectrum. Are some of your patients allergic as well?
Yes. Some of them have ABPA and asthma, and then have CPA as well. So they're quite a challenge.
Oh yes, I remember on your slide.
So that's quite a challenge to manage. Very few of them have sinus disease, interestingly. I sort of expect some of them to have sinus disease, and it seems to be not a problem, whereas that is a problem in ABPA and some asthmatic patients. So there's something different between the sinuses and the lungs, which we don't completely understand. But yes, some of them are allergic, yeah.
We've got a question at the back. Thank you.
Has there been much done with inhaled azoles?
No, is the answer to that. There isn't a commercial preparation available. They're very, very lipophilic compounds. They're not easy to compound, although there are a couple of companies that have done that, but it hasn't been clinically applied in this area. One of the challenges with inhalation generally is that the areas that are most affected in the lung are the areas that have least air going to them. So getting the antifungal into the areas with least air is a challenge, and that will be particularly a problem here.
I wouldn't expect that it would do much with the fungal masses, the aspergillomas, but with more diffuse disease it might. And also, have you had any experience using the cyclosporin in combination with it? Again, looking for potentiation of the effects of the azoles by virtue of its ability to interfere with the defenses of the fungus.
Yep. The answer is no, we haven't done anything with cyclosporin. We do know that if we treat these patients with steroids without antifungals, they get a much more rapidly progressive disease. So we are worried about immunosuppression in these patients, rightly or wrongly. We do use steroids in patients who are under control with their antifungals and have got good levels and we've got a handle on it, and sometimes they benefit from those courses of steroids. But we haven't tried cyclosporin. And I don't think anybody else has either.
Any other questions? No? Thank you, David. That was fantastic.